Good morning, everybody. I'm Larkin Feeney. I'm the chair of today's research meeting. So welcome to the St. John of God Research Foundation. You're first going to hear from Conor McCarthy, CEO of St. John of God Hospitaller Services, who's going to be making some introductory remarks and welcoming you. So I'll be back later.
Good morning, everyone. I'm Conor McCarthy, the CEO of St. John of God Hospitaller Services Group. I'm delighted to welcome you to day one of our three-day research event. While this is an annual event in our calendar, this year's event is different in two respects. Firstly, and by necessity, we have changed the format radically. And secondly, this year is extra special for us as we are celebrating our 30th Research Study Day. The format change is necessitated by the restrictions resulting from the COVID pandemic. Initially, we were disappointed that we couldn't follow the traditional conference format where everyone gathered together for a day in a conference centre. However, we soon came to realise that there are significant benefits to the format that we are using, with webinar events on 3 consecutive Tuesday mornings. One benefit is that no one has to travel, but probably more importantly, we are able to facilitate much greater participation and cover a wider range of topics. The second significant difference that I referred to is that this year we are celebrating 30 years of research. It's a hallmark of the St. John of God organisation dating back to the founder, to seek to identify unmet needs and to look for ways to improve the services we provide. That approach is probably best exemplified by the research conducted by DETECT. That's our service for early intervention in psychosis. DETECT runs one of the longest prospective first episode psychosis studies in the world. To date, their work has impacted over 1,000 individuals and has resulted in hundreds of research publications. DETECT has also informed the development of clinical programs nationally and internationally. You'll hear more about this on day 3 of the series, which is 2 weeks from now. Researching emerging and unmet needs has been more important this year than ever before with the impact of the COVID pandemic. And next Tuesday, on the second day of the series, we will look closely at the impact of the pandemic on the mental health of all age groups and on the well-being of the men and women attending intellectual disability services. The pandemic has had a major impact on our services. We've experienced a dramatic increase in admissions and referrals to our mental health services, and regrettably, we've had to suspend our respite and day services for our service users with intellectual disability. The toll on our staff and on those we support has truly been enormous. But the pandemic has challenged us to look at new ways of meeting the needs of the people we support, and our teams have responded with innovative approaches. There are many examples of innovative approaches, including the work done across our ID services in organising through Zoom a wide range of engaging and exciting activities. And in our hospital, we have developed the Living Well in the New Normal programme and switched the mental health first aid programme to online training. We must now, of course, ensure that these initiatives and initiatives like these are evaluated through high quality research, providing a robust evidence base for their use in the future. On the 24th of November, and that's the third and final day in the series, we will look more closely at innovations like these, and we will highlight how the research that we have supported over the past 30 years has influenced the evolution of mental health and intellectual disability services not just in Ireland, but across the world. During this series, we will look at what we have done over the past 30 years in forwarding the human rights of those we support. The research we will showcase and our panel discussions will assist in guiding the services, our services in the future. Our commitment to research remains strong. Over the past 15 years, the St. John of God Research Foundation has awarded over €1.5 million to fund research in the areas of mental health and intellectual disability. And over the next 4 years, we will award a further €480,000 in grant funding. We are also encouraged by the government's commitment to increased funding for mental health and intellectual disability services. We believe that the research that we have undertaken in the past and that we plan for the future will provide valuable insights into how the available funding can be spent to deliver the best possible outcomes for the increasing number of our fellow citizens that are experiencing mental ill health and for those who experience disadvantage through intellectual disability. A core value of our organisation is hospitality. Our full title is St. John of God Hospitaller Services Group. The format we are using today puts some constraints on how we can express our hospitality, but we do offer you a very warm welcome, and I would like to express my appreciation to the large number of expert presenters and to those who have agreed to chair the sessions. Today, we begin by shining a spotlight on the protection of human rights to the provision of mental health and intellectual disability services. Our speakers will discuss the ethical and legal framework under which care is provided, the personal perspective of receiving care, and the challenges encountered in providing services in a changing environment. But before I hand over to the chair for our first session, I would like to acknowledge the great support provided to our research team by Dr. Ruth Barrington and our fellow directors, and by our Research Ethics Committee chaired by Professor Mary Clark. I particularly want to acknowledge the work of the research team led by Dr. Leslie O'Hara. Leslie, together with Dr. Anya Kelly and Peter Gallagher, has developed a truly great program using technologies that are new to us. I know Leslie would also want to acknowledge the support of Patrick Quinn and the organising committee. So many thanks to all involved. I will now hand you over to the chair for the first session today, Dr. Larkin Feeney, consultant psychiatrist and clinical director for adult mental health community services. Thank you.
Okay, thank you very much to Conor McCarthy for those uplifting words to open the conference, and thank you all for attending the research study day, which will be over the next 3 Tuesday mornings. For anyone who didn't hear the first time around, I'm Larkin Feeney. I'm clinical director of the adult mental health services in Clonmara.
That's me,
so, I'm getting some sounds in my mic, but anyway, just to go on and say we've got a very great lineup of speakers this morning. We've got Professor Emily Logan from the Centre of Human Rights in NUI Galway, Anya Flynn from the Mental Health Commission, Michael Keating from HICWA, and some research presentation from Brian O'Donoghue, and then a personal perspective on recovery and how services have evolved from Michael Groves and Charles Searson. So all very, very interesting. And then at the end, we're going to have a live panel discussion with some of the speakers, and we're going to be joined by Emma Balmain, CEO of St. John of God Hospital, and Teresa Mallon, Director of Quality and Programme Development in St. John of God Community Services. So just to introduce Emily Logan, she's adjunct professor of human rights practice at the Centre for Human Rights, NUI Galway. She served as Chief Commissioner of the Irish Human Rights and Equality. Formerly, she was the Ireland's first Ombudsman for Children for 11 years prior to that, and she served as the chair of the European Network of National Human Rights Institutions and as president of the European Network of Ombudsmen for Children. Her title is Small Places Protecting Human Rights. So over to that. Thank you.
I'm going to talk to you now about the disability legislation because it had a long and tortuous history and journey, and it has its origins in the recommendations of the Commission on the status of people with disabilities dating back to 1996. And the disability bill, we ended up with the disability bill in 2001, which was withdrawn in February 2002, following opposition from disability groups and disability rights campaigners. Now, the history, we're very familiar with the history of disability charity driven largely by Catholic institutions, is now driven by a public commitment to mainstreaming equality of opportunity, also social inclusion, and more recently, human rights. And what followed the falling of the bill was a series of public protests and meetings which heralded the arrival of disabled people's civil rights movement in Ireland. So while people had been aware of what was going on internationally, the frustration of the journey of the Disability Act in Ireland was such that people took to the streets and decided that they'd had enough. And the argument, the tipping point really was about providing legislation that would allow people to go to court and the justiciability of human rights. What I'd like to do now is just talk to you about the disability legislation and its long and tortuous journey, and how that journey was actually instrumental in terms of people with disabilities themselves having a voice. And it has its origins in the recommendation of the Commission, as I mentioned, on the status of people with disabilities in 1996. And we ended up with a disability bill in 2001, which was withdrawn in February 2002, a year later. And it was following opposition from disability groups and disability rights campaigners. And this was largely because of the lack of enforcement of disability rights, in particular in the courts. And while the history of disability, the charity driven largely by Catholic institutions, is now moving to a public commitment to mainstreaming equality of opportunity, to social inclusion, and then more recently, human rights. But when that bill fell, what followed was a series of public protests and meetings, which is described by Judy Walsh, who's been prolific on her writings in equality and human rights, as heralding the arrival of disabled people's civil rights movements in Ireland. The Supreme Court judgment happened just around the same time as the disability bill was published in 2001. People will remember Jamie Sinnott, a young man with autism, whose mother fought and took years to get through the courts to finally getting to the Supreme Court judgment, which was instrumental in accelerating disability rights, because it accelerated two things. One was political action on disability rights. It jolted the political system into understanding that they had an obligation for people with disability. And the second was that it attracted huge media and public support. And if anything, it propelled a social movement. It really garnered support from people outside the disability sector and disability activism. And one of the key stumbling blocks to the Disability Act that continued to progress after that was Section 47, which provided that no element of the legislation could be enforced in the court. And if anything, post the Senate judgment, they were even more adamant not to legislate or include in legislation rights that could be enforced in the court. People will remember the late Donald Tulin, an incredible human being. But Donald said that the disability bill appeared to be an attempt to restrict the use of the courts system to vindicate rights where agreed actions were not forthcoming. And to date, that remains where we are in terms of the enforceability of rights in the court. The bill collapsed, putting disability rights firmly back on the political agenda. And then a body called the DLCG was set up. The Disability Legislation Consultation Group was established from 8 disability organisations. And in the Act, really what it boiled down to was a statutory entitlement. And we've heard this recently from parents in the media about the entitlement to an assessment for help and education needs, which is a very minimal approach to the provision of disability rights. Certainly the disability sector and laterally the human rights, broader human rights sector advance a much more expansive version of disability rights. And the Disability Act is considered by many to represent a missed opportunity in terms of safeguarding disability rights in Ireland, notwithstanding the very great efforts by people with disability, by their families, by their carers, by people who are advocating for them, who fought long and hard for the Disability Act. Looking now to international human rights law, because what I'm well aware that Anya Flynn is coming behind me and then Michael Keating from HICWA, and I'm trying not to overlap with what they might say in terms of national legislation. So I'm going to move to the international framework and international human rights law. And by ratifying a treaty, a state assumes obligations to respect, to protect, and to fulfill. And an obligation to respect means that the state must refrain from interfering with or curtailing the enjoyment of human rights. An obligation to protect requires the states to protect individuals and to groups against human rights abuses, and an obligation to fulfill. And that fulfilling, often the burden of fulfilling those obligations fall mainly on the state, but doesn't mean that the rest of us can't take any action. But the obligation to fulfill means the state must take positive action to facilitate the enjoyment of basic rights. Now, in the context of providing a service, you have a job to, in particular, to respect human rights, to make sure and to consider any of the practices or policies that exist in your organization respect human rights, which means you make every effort not to interfere with or curtail the potential enjoyment of human rights, and that you don't simply see yourselves as protector of human rights, but people with power to write policies, to guide practice that makes sure that people have an experience of enjoyment of human rights. In terms of the approach specific to the United Nations Convention on the Rights of People with Disability, which Ireland ratified finally as the last country in the European Union, ratified in 2018. There are a few important things to consider about it. The first is that it does not introduce any new rights. Ireland has signed a significant number of UN treaties, and the rights contained in the Convention on People with Disabilities exist in other treaties. What it does do is it seeks ways to support and celebrate human diversity by creating conditions that allow for meaningful participation by everybody, including people with disabilities. So you heard me in the last slide talk about the negative side, if you like, of human rights that people are probably most familiar with, which is about the prohibition of discrimination. But what the Convention does is it shifts away from the prohibition of discrimination to a more positive aspect of human rights, a much more emancipatory side of human rights, which recognizes the individual, the potential of every individual, and the potential for the rest of us to celebrate human diversity and understand and support people with disabilities to meaningfully participate in this context, in their service provision or in receipt of care. And instead of a focus on the disability, it seeks to assist people help themselves. So it's about moving away from people as passive recipients of our decision making to a place where we recognize people as participants in the exercise of their own human rights, helping people to participate in society, in education, in employment, in political and cultural life, and to defend their rights through accessing justice. And you will hear, I suppose there is a terminology, and it's worth, when you're considering the application at an operational level, it is worth looking at some of the language of the convention, because it speaks to all people with disability. And that includes, in particular, when you're providing a service for people who may be described as non-verbal. It doesn't always mean that they cannot communicate. They may not be able to verbalize, but they're accepted internationally under the convention as being able to communicate their will and preference. And that the burden is on those of us who are providing services to support people with disability in expressing their will and preferences. And I'm sure Anya Flynn will speak more to that later on. And the other thing to note is that the UN, the Office of the High Commissioner, actually discourages governments and states from including the disability portfolio in a Department of Health or in a Department of Social Welfare, as it perpetuates the idea of either a medical model or reliance, the link between social welfare and disability and reliance on the states. And we have a new department now with a new minister, and hopefully we will see greater movement and accelerating in terms of disability rights. So one of the things that the Human Rights Framework does, it puts the person at the center of the service, and to support people within the service, what it also does is overwrites it, if you like, with a regulatory framework. And some of these regulations or regulatory bodies exist prior to the introduction of the UN Convention in Ireland. They'll be familiar to everybody. So the Office of the Ombudsman has a very particular role in relation to the 2005 Disability Act. The Ombudsman for Children has a very particular role in relation to the EPSAN Act and the implementation of the EPSAN Act. And then you have organisations like the Garda Ombudsman Commission, which don't immediately strike people as having a role in relation to people with disabilities, but in the course of detaining people, in particular in Garda stations, or in situations where under the mental health legislation, Gardaí may be involved in service provision. You're familiar with the Mental Health Commission and the decision-making support unit there, led by Anya Flynn. We also have the Workplace Relations Commission Act, and that is a complaints handling body for people in the context of the equality legislation, whether it is equality of opportunity or equality in the context of goods and services. Then we have the more recent entrant of the Health Information and Quality Authority, who I would commend in terms of their efforts dating back to 2018 to very publicly describe the change in their approach. And if you look at their corporate plan, you will see a shift in language. And Phelim Quinn has spoken about this publicly, to a human rights compliant assessment and regulation framework. And we also have the Inspector of Prisons, and this is broadly speaking about disability now. And the Inspector of Prisons, of course, in a place of detention, the deprivation of liberty is being changed there by, under that heading on development, you can see the optional protocol and the Convention Against Torture. And that is really about, even though for some people there's slight discomfort around the use of the term torture, if you think more carefully about the prevention of inhuman and degrading treatment. And essentially that's what is and will be coming down the line, is a redefining of deprivation of liberty and what it means. And it will be defined beyond the usual places of detention that we are familiar with, like prisons, into residential and social care centres. So it will become part of the regulatory framework in the future. In addition to the optional protocol, on the Convention on the Rights of Persons with Disability, there is a regulatory framework, and it will involve some of these organisations that already have a role, and they will be brought together and probably coordinated by another authority. That could be the Inspector of Prison, the Ombudsman, or the Irish Human Rights and Equality Commission. I'm not sure if that has been published yet, but there are efforts afoot to bring together what's known as a coordinating mechanism to have oversight of the optional protocol. And there will also be an effort to coordinate oversight of the UN Convention on the Rights of People with Disability, and that will be led by the Irish Human Rights and Equality Commission, that now has a Disability Advisory Committee, and that Disability Advisory Committee is provided for in legislation. And it is important in terms of thinking about regulation, is about thinking about how people with disabilities can participate in the governance or at different levels in your organization. So it's not simply about providing the service. And the UN Human Rights Council has identified what they describe as key attributes of good governance. These principles are familiar to everybody: principle of transparency, responsibility, that the burden is on the people who are providing the service to support people with disability. Accountability is not new, but participation, the principle of participation, is new. How you share that power for good governance with the people that you provide a service to. And in the context of St. John of God's, it's people with disabilities. How do you think about or ensure the participation of people in the mental health service and in the intellectual disability service? And it's also about responsiveness to the needs of the people that you serve. One of the key changes and obligations that was introduced in legislation back in 2014 was in the Irish Human Rights and Equality Commission Act, through what is known in section 42 as the public sector duty. And that is a duty to eliminate discrimination and to have regard and respect human rights. So this information is taken from the Irish Human Rights and Equality Commission website, and they have a lot of material and information if you want to link in with them at an operational level to understand what it is you have to do. But the guidance outlines how you might include in your service, or certainly how you, not how you might, how you must comply with this new legislative obligation. And it suggests 3 ways of doing that. The first is you have an obligation to assess. So any public body is required to set out in its strategic and corporate plan an assessment of the equality and human rights issues relevant to your service. The second is that the public body is required to set out its policies, its plans, and the actions it's going to take to address issues in relation to equality and human rights. And the third is about reporting in your annual report on the developments. And in fact, a good model of that is to look at the HICWA model, where you can see in HICWA's corporate plan, and then you can see in their annual report how they're reporting on the development of human rights issues and actions that have been taken. And there's also an obligation on public bodies to ensure that how you communicate is communicated in a way that is fully accessible to the public. Now, I have just a 3-minute video here that I hope will work, and it's just a short video helping you understand how you might implement the public sector duty.
People in Ireland rely on services provided by public bodies on behalf of the state every day. From colleges and hospitals to libraries and the courts, these services are essential, and it is important that they can be used by everyone. The public sector equality and human rights duty is a legal obligation on you as a public body to eliminate discrimination, promote equality of opportunity, and protect the human rights of your staff and the people who use your services when carrying out your daily work. It's a positive obligation that requires you to be proactive, to think about human rights and equality issues in your work and address them before they become a problem. The duty applies to the whole organisation, including corporate services, procurement, human resources, service provision, research, policy and regulatory functions. To meet the core requirements of the duty, you must assess, address and report. First, assess. You must carry out an assessment of the human rights and equality issues relevant to your work. This assessment must form a part of your strategic or corporate plan, which should be accessible to the public. The assessment should be based on evidence. Input from staff and people who use your services is key, as is using internal and external sources of information and data. Remember that equality does not always mean treating everyone the same. It is about considering the particular needs of people so that similar outcomes can be achieved. Certain people or groups of people may be more at risk than others of experiencing discrimination or human rights violations, and careful consideration must be given to include these concerns. Secondly, address. You must set out in your strategic or corporate plan the policies, plans and actions to address any issues raised in the assessment. You can include actions you may have set out under different national strategies or policies, or under the public sector reform programme that are related to equality and human rights. You will need to think about positive actions you can take to meet the needs of people at risk and consider reasonable accommodation for people with disabilities. Finally, report. You must report annually on progress and achievements in a manner accessible to the public, such as your annual report. Integrating the duty into your strategic plan and annual report means that it is an ongoing obligation that must be monitored, reviewed and developed in each strategic planning cycle. The duty has the potential to positively transform how public bodies engage with members of the public and their own staff, to make Ireland's public services more inclusive and more effective, and to achieve an Irish society where everyone and their rights are treated with respect. The Irish Human Rights and Equality Commission has produced a guidance for public bodies on implementing the duty. You can access this guidance and learn more at ihrec.ie.
Bear with me as I move to the next slide. So that was the public sector duty. I think you will hear from Michael Keating about HICWA, how HICWA have approached their responsibility and their compliance in that regard. So in terms of concluding now, and in terms of what I was asked to do by Leslie, which was look at protection of human rights, I want you to think back to those three responsibilities that people have in relation to implementing human rights. So it's about protecting, it's about respecting, and it's about fulfilling. And in particular, for those of you who are providing services, you can look at protecting and you can look at respecting by ensuring that there isn't anything that you're doing that might interfere with the rights of people with disabilities, and then protecting to create policies and practices that are healthy, practices that engage people with disabilities. They have been in the past. So viewing disability from a human rights perspective involves an evolution in thinking and acting by states and all sectors of society so that persons with disabilities are no longer considered to be recipients of charity or objects of others' decision-making, but as active participants in the exercise of their own rights. And it's about celebrating human diversity. We know that there are 13% of Ireland's population now have a disability. And now that we do collect data, we know that that signifies over 643,000 people in Ireland who are now looking to the UN Convention on the Rights of People with Disability and Ireland's implementation of it. And they're doing that to ensure the full and equal enjoyment of all human rights and fundamental freedoms of all persons with disabilities. promoting respect for their inherent dignity and their freedom. So in conclusion, I would like to really, in short, to say that I'm delighted that you're having this conference. I'm delighted that you're exploring human rights and how the framework for human rights can place people at the center of a service that is human rights compliant, a respectful service that respects people's dignity and freedom. And in my experience over many years, it has brought a huge enjoyment, a huge insight that I didn't have before, to work alongside people with disabilities. The lens through which you look at a service becomes different. And for everybody, it is, of course, a much richer experience and a much more respectful environment in which to operate. My thanks to St. John of God's for your time. Thank you very much for listening. I wish you all very well. I hope the next sessions today and the sessions over the coming days go very well for all of you. In the meantime, thank you very much, and I look forward to hearing publicly about all of the advances in human rights compliance in St. John of God's. Take care.
So thank you very much, everybody, for listening. And that was Emily Logan giving a very interesting talk, updating us all on human rights developments in Ireland. So I know some people have been having some technical difficulties within the St. John of God network that we're trying to sort out, so apologies about that. On the timetable, there is now a break scheduled before we go on to hear from Anya Flynn and Michael Keating. So if people want to go off and get a cup of coffee, there's actually about 15 minutes before the next talk is due to start at 10:25. Thank you, everybody. Okay, everybody, welcome back. And we now will be going on to the next couple of talks. And excuse me, I know some people were having difficulty with the on the St. John of God network. So, but if you're on a 4G or home network, you can see it fine. So hopefully, anyway, we'll get it sorted out. So our next talker is Anya Flynn, who she graduated in law from Trinity College, Dublin, and completed a research master's in criminology and criminal justice policy. She's been a solicitor since 1989, and from 2002 to 2017 was senior partner specializing in public interest law, including disability and equality law. She's written and lectured on human rights and has been a member of the Human Rights Committee of the Law Society since 2012. Prior to her present appointment, she was a member of the Law Society's Mental Health and Decision-Making Capacity Task Force. On 2nd October 2017, she took up office as the first director of the Decision Support Service. And her talk today is entitled The Assisted Decision-Making Capacity Act 2015 in the Context of Mental Health Services, Overview and Update. So over to Anya.
Thank you. My name is Anya Flynn and I'm Director of the Decision Support Service. That's the new service established under the Assisted Decision Making Capacity Act of 2015. And thank you to St. John of God Research Foundation for having me to present to you. What I would propose is to provide a brief overview of the main provisions of the Assisted Decision Making Capacity Act. I will say a little bit about how that interacts with the Mental Health Act and with mental health services more generally, and then give you some idea of where we are on the pathway to implementation. And I propose dealing with the Act itself quite briefly. I know that some of you will have a level of familiarity already. So it is in its long title then described as an act to provide for the reform of the law relating to persons who require or may assistance in exercising their decision-making immediately or in the future. It is fully enacted legislation signed into law by the President right at the end of 2015, but not yet fully commenced. So a lot of what I'm talking about does relate to the post-commencement stage. The Department of Justice indicated by their estimates that more than 200,000 people could be affected by this act, and included within that number they had 100,000 people or thereabouts who are adults with long-standing mental health conditions which may affect their decision-making capacity. It's important to say that it's not necessarily true that any one of that number necessarily will require the supports offered by the Act. That will depend entirely on individual circumstances. And to give a little bit of international context, the commencement of the Act has been identified as essential to Ireland being compliant with the United Nations Convention on the Rights of Persons with Disability, which Ireland signed right at the beginning of 2018. And that's an international convention which obliges Ireland to ensure and guarantee the rights of persons with disability and their equal recognition before the law. And the social model of disability which the Convention adopts includes those with enduring mental illness. The key reforms under the Act include the abolition of our current wards of court system. Some of you will be familiar, or people in your services who are wards of court, and you will be aware that in order to make healthcare decisions around wards, you have to refer to the court. So post-commencement, there will be no new applications for wardship, and all people who are currently wards, and there are over 2,100 or so of those, all current wards will exit wardship and transition, if necessary, to the new supports within 3 years of commencement. And I'll now just touch on the other key reforms. And first of these then is the statutory functional assessment of capacity. So there's no diagnostic criteria or medical type threshold for a finding of incapacity. And in this respect, the Assisted Decision Making Capacity Act contrasts with comparable legislation in England and Wales, which describes incapacity as deriving from a disturbance or an impairment in functioning of the mind or brain. With limited exceptions, the Act is not prescriptive or exhaustive about who may assess capacity. And a person lacks capacity then on this analysis if that person is unable to understand, retain, weigh up the information which is relevant to making a decision, and then communicate with appropriate assistance if necessary what their decision is. And important to say, this is merely putting on a statutory basis what already is the applicable standard at common law and policy. So you already see that functional assessment in medical council guidelines and, for example, in the HSE national consent policy. So it's how capacity is supposed to be assessed already. The guiding principles, and these are just some of them in the 2015 Act, include a statutory presumption of capacity, again, already the applicable standard at common law. There's an obligation to support persons to make their own decisions as far as possible. And in that regard, I've sometimes said that, in a way, the brackets in the title of the Act, the Assisted Decision Making brackets Capacity Act, are significant because the priority of this legislation is about supporting people to exercise their decision-making autonomy. It shouldn't be seen as an act which has new things to say about how to assess capacity, how to access consent. It does have things to say about that, but those aren't the priority. The focus is to help people as far as possible to make their own decisions. And in so doing, they have what is sometimes described as the right to be unwise, or more accurately, what the Act says is that wanting to do something that seems unwise doesn't mean that you lack the capacity to decide to do it. Dignity, bodily integrity, privacy, self-determination and autonomy, those are key themes within the UN Convention, and you will see them at Section 8 of the 2015 Act. Giving effect to past and giving effect to will and preference is something which is seen as very much central to compliance with the UN Convention. There's a duty also to act in good faith and for the benefit of the person, and you will see that there is nowhere in the 2015 Act a reference to best interests, and in that respect this Act contrasts with the current mental health legislation. The Mental Health Act of 2001 has at Section 4 best interests as the principal consideration. I won't go into this slide in detail. What I've set out here are the categories of decision as defined by the Act. They divide up into two broad categories: property and affairs and personal welfare. And all these sort of decisions are decisions which are now capable of being supported within the new structures provided by the 2015 Act. And you will see healthcare there under personal welfare. Of decision supporters, ranging from the decision-making assistant at the lowest and least interventionist tier, co-decision making, which is a process of joint decision-making, and then as a last resort, there is still an opportunity to apply to the court, now the Circuit Court. It's mostly the High Court under wardship, and then a decision-making representative can be appointed by the court, who then takes their authority from the court order and can make decisions on behalf of the relevant person who has been found to have capacity for those purposes. All of these are supervised to varying degrees by the Decision Support Service and are bound by the guiding principles which I've just mentioned. The Act also has things to say about advanced planning, and to that extent it's an Act for all of us, as we could at a future point in our lives lack our decision-making capacity. We already have enduring powers of attorney, but under the 2015 Act, attorneys can be appointed to make healthcare decisions. They will be under new reporting requirements and supervision by the Decision Support Service. And then advanced healthcare directives, again, are put on a statutory footing by the 2015 Act. And their purpose is to enable persons to be treated according to their will and preference, and importantly, to provide healthcare professionals with information about a person's treatment choices. It's a standard principle and a starting point that treatment is predicated on consent, and that anybody, any adult with capacity, has the entitlement to refuse treatment on whatever grounds. And what the AHD, the Advanced Healthcare Directive, then provides is an opportunity for you to set out that refusal of treatment in advance. And a new creature is created called a designated healthcare representative, essentially a person's agent who will follow through on the Advanced Healthcare Directive. I have a little bit more to say about how these interact then with the Mental Health Act. The Decision Support Service, so that's located in the Mental Health Commission. You'll be familiar with the Commission and you will know that it already does quite different things to do with the regulation of acute mental health services and the mental health tribunal system. So this takes the Commission in quite a different direction, obviously with a different statutory remit. Just to call out a few then of the functions which are set out in the Act, we will have a duty to promote awareness and confidence and to support organisational change so that people are supported in the exercise of their capacity. And I will come again to the codes of practice which you can also expect. So just to be clear, we have a regulatory function, but that's in respect of those decision support arrangements. So we don't suddenly have a regulatory duty in respect of healthcare providers. But I suppose these are those which will be important in practice. And looking again at advanced healthcare directives, if a person is being treated under the Mental Health Act, under Part 4, which deals with involuntary detention and the administration of treatment, then an advanced healthcare directive is not binding if it relates to the refusal of treatment for a mental disorder. So remembering again, an advanced healthcare directive only applies at a future point when you have lost capacity, but if at that point you're a detained patient receiving treatment under Part 4 of the Mental Health Act, then to the extent that your advanced healthcare directive refuses treatment for a mental disorder, it is not binding. However, it is still binding if in your AHD you're refusing treatment of a physical illness. Well, that's been subject to some debate, and indeed an amending bill in 2019 proposed to remove this exception, and that was broadly supported, including by the Department of Health. So we have to see how that progresses and whether that exception will in fact be retained. Another express reference to the Mental Health Act in the Assisted Decision Making Capacity Act concerns detention provisions, and the Act says this at Part 10, that where during an application to court, which could be the Circuit Court, could be the High Court, as to whether a person who lacks capacity is suffering from a mental disorder within the meaning of the Mental Health Act, then the Mental Health Act procedures will apply in relation to any proposal to detain. And where at the commencement of the Act, the person is already detained in an approved centre under order of the Wardship Court, which can apply in a minority of cases. You may be aware of, if you are working in approved centres, of 1 or 2 people who are there on order of the Wardship Court rather than under the Mental Health Act. Where that arises upon commencement of the Act, the Wardship Court will review, and if the Wardship Court is satisfied that a mental disorder is present, then the court can direct continuing detention for those periods of 3 months, 6 months, subject to ongoing review. And as pertains to mental health tribunals, we'll hear from the responsible consultant psychiatrist and also an independent consultant psychiatrist. And finally then, by way of express reference, the Act does state that nothing in the 2015 Act authorises a person, which could be one of these new decision supporters, to give a patient treatment for a mental disorder or to consent to a patient being given treatment for a mental disorder if at that time treatment is regulated by Part 4. So again, if somebody is involuntarily detained and are being treated under Part 4 of the Mental Health Act, then there's a specific exclusion in relation to the supports or the role of a supporter under the 2015 Act. I hope that's clear. I'll be able to take questions, I think, in relation to that. Now, pardon the double negative here, but at this point in the Act, it doesn't say that the 2015 Act does not otherwise apply. So by calling out this specific exception, I think the 2015 Act is saying that otherwise the 2015 Act is relevant and is to be adopted and to have real meaning within mental health services. So it isn't as if the Mental Health Act relates to mental health services and the Assisted Decision Making Capacity Act is about all other categories of persons. So what are those broader implications for the mental health services? And here I suppose I'm moving from the specific to the more general, and just by way of suggestion in preparation for commencement, and those of you working in mental health will have your own and perhaps better ideas. You might think of reviewing your standards, policies and processes to ensure compliance with the Assisted Decision Making Capacity Act, to adapt your existing documentation forms, templates and checklists and so on to ensure that they are compatible with the 15 Act. I presume you have already your own way of documenting how you record consent, for example, under Part 4 of the Act, or capacity to consent. To ensure accessibility of information and appropriate communication tools, remembering again that duty to ensure that people are supported as far as possible to make their own decisions, and that they shouldn't be at risk of being found to lack capacity because their opportunity to communicate is in some way limited. So we would see that access to the Act and to the supports under the Act are very much a new feature of care, and that will include within mental health services. And people working in those services, I guess, will have to become used to interacting with new decision supporters who will have legitimate roles. And to address this idea of the next of kin, this is something which I hope is on the wane, but certainly was very pervasive. The idea that by virtue of a family relationship, somebody describing themselves as next of kin somehow had an automatic decision-making role or an authority to supply consent, which is not now and never has been true. This obviously points to training and professional development requirements, and I'm sure that people in services will have an opportunity to call on their employers and their regulators or the representative bodies to ensure that training, and I know that training has been ongoing including this event, to ensure that training is in place, and as I've mentioned, we in the DSS will be happy to cooperate in that regard. Where are we in the pathway to implementation? The DSS establishment project is well underway. The department was primarily justice and equality. We have now moved to the new department, children, equality, disability, integration and youth. And they have recently, as recently as yesterday, I think, when speaking to the Oireachtas committee, have indicated a commencement date of 2022, further off than many of us might like, but that does seem to be on track. Amending legislation and regulation are still being drafted, so the Act itself is to undergo some amendment. There have been various submissions about where it needs to be reconsidered. One of the most substantive amendments, I think, will come with Part 6 and amendments to secure the position of current wards of court. Quite separately, protection of liberty safeguards are being developed by the Department of Health, and they will deal with the circumstances for people who lack capacity to consent or a living situation where they are under continuous supervision and not free to leave, and how to ensure that that is safeguarded by an appropriate legal process, because there really isn't one at the moment. I've mentioned codes of practice already. They are with us already in the DSS in draft form, and those will include codes of practice for health and social care professionals. There will be a code to deal with assessing capacity and supporting decision making, and specific codes in relation to advanced healthcare directives, and all of these will go out for public consultation before they are published by the ministers. Very briefly then, I suppose it's over to one side, but amendments to the Mental Health Act itself are in train. There is a Mental Health Amendment Bill, which is at the heads of bill stage, and that's described as having it as its purpose to amend the Mental Health Act of 2001 to give effect to the recommendations of the expert group review, which I think reported as long ago as 2014, if I'm right. The Mental Health Commission has been providing submissions on draft legislation, and without going into too much detail, a priority for the Commission, my colleagues in the Commission, will be to ensure conformity between the Mental Health Act and the Assisted Decision Making Capacity Act, a consistent approach to those definitions of capacity, consent and voluntariness, compatibility between the guiding principles, and overall a parity between mental and general health, which has always been a key theme for the Commission. So, and I'll finish with this. Much has been made, I think, of the cultural shift that will be involved with commencement of the Assisted Decision Making Capacity Act. And I think whilst there is a lot in it that is new, and I'm sure that there will be some challenges associated with that, I think it's important not to overstate the newness, because person-centered care and participatory decision-making is already the standard, and I've no doubt that people working in mental health services already do that almost without thinking about it. I've set out here what are called the freedom principles, which relate to a human rights-based approach in health and social care, and those ideas of fairness, respect, equality, dignity and autonomy, which are at the heart of the 2015 Act, but I'm sure are very much already at the heart of everything that you do. So I will finish with that. We have launched a website just a couple of months ago. I've set out the web address there. It provides more information and also some detail on where we are as we move towards commencement and the preparations which you might think of undertaking. So thank you very much for listening to me, and I know that I will be available for some questions. Thank you.
Now, thank you very much to Anya for that extremely thorough update on where we are with the Capacity Act, and good to know it's going to finally be with us because we've been waiting quite some time. So Anya will be back for the live discussion, so we'll get some more from her, so that's great. Next on to introduce Michael Keating from HICWA. He's been working with them since the commencement of the regulation of disability services in November 2013. He's currently a regional manager within the disability pillar, covering the counties of Dublin, Kildare and Meath. He completed an MA in healthcare and public management with the Institute of Public Administration in 2012. He was a member of the Restrictive Practice Expert Advisory Group, which was tasked with developing the thematic program. He's taken the lead role out of the thematic inspections and has overseen all of the inspections to date. So his talk is entitled Promoting a Care Environment that is Free from Restrictive Practices.
Hi, my name is Mick Keating and I'm a regional manager within the disability pillar in HICWA. So thank you for your invitation to participate in your 30th Research and Evaluation Study Day. It's great to see the focus this year on human rights. My focus is on restrictive practice and specifically the impact of these practices on the lives of people with disabilities, looking at how we work towards promoting a care environment that is free from restrictive practice. So we will look at how we protect and promote human rights in residential services. And by the end of this short presentation, we will have examined the legal framework in which HICWA protect and promote people's human rights, explore the impact of restrictive practices on the quality and safety of care provided to people in residential services. So the overall aim of HICWA is to improve the quality of lives and safety of people living in residential care. People have the right to live as independently as possible without unnecessary restriction. And one way this can be achieved is where providers and staff take a positive and proactive approach in reducing and eliminating restrictive practices. Our inspectors look for evidence that people's fundamental human rights are upheld, that their voices are heard, and that they are free to live in accordance with their choices and preferences. So what are human rights? Human rights are the basic rights and freedoms that all people should enjoy. People that avail of services, human rights are about people being treated with fairness, respect, equality, and dignity. So ensuring people have a say over their lives and participating as fully as possible in decisions about their care and support. There is a duty on the state and on health and social care providers to uphold the human rights of people using services. In recent years, there has been an increasing focus on human rights, autonomous decision-making, empowerment, and choice in health and social care policy and practice. And this has highlighted the importance of moving away from a paternalistic approach to care and support towards embedding human rights into service provision and organizational culture. So, a human rights approach to care and support is underpinned by a legal framework and human rights treaties which states have agreed to uphold. So this legal framework places a responsibility on health and social care providers at an organisational and individual practitioner level to uphold the human rights of people using their services. Legal sources include the Equal Status Act 2000 and 2015, the Irish Human Rights and Equality Commission Act 2014, capacity legislation, and the ratification of international treaties such as the United Nations Convention on the Rights of People with Disabilities 2006, which was ratified in Ireland in 2018. So during my short presentation, I'm only briefly referencing some relevant legal frameworks, and I've no doubt you will be exploring all of these in more detail in other sessions. So the freedom principles. Although human rights exist in law, it can be useful to think of them in your day-to-day work in the context of principles. And FRIDA is an internationally recognized framework through which human rights can be considered. The FRIDA principles are the basics of good care and form part of what health and social practitioners already do on a daily basis. Human rights are about being treated with fairness, respect, equality, and dignity, and having a say over their lives and participation as fully as possible in decisions about their care and support. Please refer to our HICWA guidance on human rights-based approach in health and social care services, which provides more detail on the FRIDA principles. So human rights and restrictive practices. It's important to recognise the requirement to have an open, transparent system in place, which ensures due process has been adhered to whenever a person's rights are restricted. And this should also take into account the possibility for any restriction to impact upon the rights of other people. So a big issue is the impact of restriction assessed as required for one individual, impacting upon the lives of other people who that person lives with. So the locked front door, the use of physical restraint, and the impact of others witnessing this type of restraint. So we need to consider this impact and look at compatibility assessments for residents living together. So what is restrictive practice? It is the intentional restriction of a person's voluntary movement or behavior. And that's the definition from the regulations. They may be physical or environmental in nature. And they may also look to limit a person's choice or preference. And this is known as a rights restriction. So being overly risk adverse or no positive risk taking being considered. So in terms of physical restriction, so holding a person back to prevent them causing harm to another person or to themselves is obviously a restrictive practice. And MAPA or other types of interventions, sometimes there was an assumption that because the resident was assessed as requiring a type of hold, that this made it okay. Again, we must focus on removing the need to use such restraint and keeping it under constant review. So environmental restraints. So restricting residents' normal access to their environment, such as locking the door of the kitchen or locking away the kettle where a person may be assessed as being at risk from scalding. And then finally, the rights restraints. And these are often more difficult to recognize, more subtle. So for example, limiting or denying access to cigarettes or to certain foods. So the use of restrictive practice of any kind should only be a measure of last resort where there is imminent risk of serious harm. An episode of restraint is a temporary measure and should always be in the least restrictive form and used for the least amount of time necessary. So the legal position is that in general, the application of restraint on a person without their consent is unlawful. From a European Convention on Human Rights perspective, the use of restraint can only be justified if it is a medical or a therapeutic necessity. The standard of proof required to establish this is very high. So in terms of individual decision making, so in the exceptional circumstance that an episode of restriction is initiated, it must be minimized to what is absolutely necessary and should always be viewed as a temporary measure. We must always remember to weigh up the risk involved in carrying out an activity with the benefit that that activity may have for the person. So there is a dignity of risk. Residents have the right to participate in activities involving personal risk. The desire to maximize resident safety does not of itself justify restraint. So, the importance of residents' views. We must acknowledge and recognise that all adults have capacity to make choices about their own care, and every effort must be made to provide information to the resident about an episode of restraint in a way that is most appropriate to help them to understand. We need to consider alternatives to restrictions. Every effort must be made to determine and alleviate the underlying cause of residents' behaviour. All alternative interventions must be explored. Providers must ensure that there are appropriately skilled and qualified staff available at all times. And a long-term management strategy should be formulated for any resident with recurrent behavioural problems. So in terms of HICWA regulations and judgments, so a judgment of compliant suggests that the provider is demonstrating that it is committed to removing, reducing, or reviewing restrictions and has a positive culture towards promoting people's liberty and autonomy. So the creation of a comfortable, safe, relaxed environment where individuals feel valued, confident, and secure reduces the need for restrictive practices. So I guess in relation to Regulation 7, which is positive behaviour support, we are saying that the centre does not have to be 100% restraint-free to achieve a judgment of compliant, but it does have to be committed to removing the restriction. So in terms of governance and leadership, as with all areas of care provision, proper governance arrangements are essential in ensuring that restrictive practices are implemented according to relevant legislation and human rights principles. We must implement a strategy to continually reduce or eliminate the use of restrictive practices. And we must recognise the importance of good quality training and education for its staff, which has proved effective in the reduction of the use of restrictive practices. So thematic inspections and our findings so far. So I suppose firstly, we must recognise the impact of COVID-19. So in March, when COVID-19 changed the world, the Chief Inspector suspended all non-risk-based inspections in response to the increased pressure COVID-19 had placed on providers. However, the findings from thematic inspections up to that point were that there was good recognition of physical and environmental restrictions. Providers were identifying customs and practice issues. The use of consent forms had started a conversation with residents and families, creating healthy discussion on the why and when of restrictive practices. And creative independent living models had significantly reduced the need for restrictive practices. Some examples that came up was where a resident in a wheelchair cannot open a door and the staff member has to do this for them. This was seen as a restriction as the resident was reliant on staff to do it. So now they're looking at a different type of door or means of door opening. Or in another centre where they had to leave the doors open so residents in wheelchairs could move around freely. However, a potential restriction was also identified here as there was an impact upon the privacy for residents as they cannot close their doors independently. So, positive outcomes for residents. There was evidence that historical reasons for the implementation of restrictive practices, such as response to resource issues, lack of staff training, and poor understanding of behavioural support needs, is no longer as prevalent. And there was lots of good examples of how the provider, through their actions, had improved the quality of life for all residents. So I suppose some challenges that were identified. So prescribed supports or enablers were not subject to review or robust assessment in the same way, and their presence may therefore not be questioned. So the rationale for these may be clear. However, the consequence for the use of the prescribed item is often the restrictive practice, so such as the use of alarms, monitoring systems, splints, and the response of staff. So they may be a less restrictive alternative, but needs to be assessed and monitored to ensure that it does not restrict the person in their movement or their behaviour. So as I mentioned, prescribed supports are also referred to as enablers. So, bed rails as enablers is something that we will all be familiar with. However, calling this an enabler is questionable, and the guidance for inspectors is that this may be a legitimate practice, but it should still be called a restrictive practice and assessed and reviewed as such. Other challenges. So I suppose identifying rights restrictions. So where there was where residents had limited access to their own money, inherited restrictions often linked to decongregation, and house rules that were in place which were deemed not which were deemed restrictive, so not allowed to have tea in their bedrooms. So practices that were in place in larger settings had made their way to community homes. For example, door alarms, hourly checks on residents at night without an assessed need being identified, centralised kitchens and set meal times. So St. John of God is an organisation that has had great success in recent years in moving residents from congregated settings to community homes. And we need to be cautious in ensuring that institutional practices that may have been used previously are not replicated in their new living environment. On one such inspection that I was on, staff members spoke to me about one resident who had moved from a large campus to a really beautiful community house. And this resident began to show an interest in food preparation, which nobody had expected. And it started with the smell of the food being prepared, you know, the food being prepared in their kitchen. And the resident began to go into the kitchen when they got the smell of the food. And then they began to show an interest in the vibrant colours of the vegetables. So looking at the tomatoes and the peppers and handling them and then being involved in the food preparation in relation to them. Staff engaged with them during the food preparation, and this actually led to a more varied diet for this resident over time. So this really makes you think. This was an experience that had been denied to this resident for many years. Nobody knew. Residents have a right to be involved in the everyday activities of living. So in conclusion, residents have a right to live unrestricted lives. It is the responsibility of the provider to ensure rights are promoted and protected. Our work is to support this approach in a critical area, but the improvements and good practices that we observe are to the credit of staff, management, and the providers. Thank you very much for your time today, and I look forward to answering your questions in the panel discussions later today. Thank you.
Okay, thanks very much, Michael. That was very interesting, and we do look forward to talking to you again in the live discussion at the end. So we've scheduled a very short break. We're just going to take 3 minutes, so run off and do whatever you need to do, because we're going to be coming back on at 11:05. So thank you. Okay, everybody, hope you managed to do something useful with that very short break. So we're moving on to the next speaker with us this morning, who is Professor Brian O'Donoghue over in Melbourne, and he's going to be relocating to Ireland soon, so we're all very excited about that. But he is a consultant psychiatrist with the Early Psychosis Prevention and Intervention Centre, EPIC, at Origin Youth Health, and a principal research fellow with the Centre for Youth Mental Health at the University of Melbourne. Brian graduated from medicine from UCD and obtained a master's degree in epidemiology and public health from the University of London and a PhD from UCD in 2015. Brian was awarded an NHMRC Early Career Fellowship for 2018 to 2021, and he's an associate editor of the Irish Journal of Psychological Medicine. His area of research interest is youth mental health, physical and sexual health of young people affected by mental health disorders, epidemiology, and the reduction of coercive restrictive interventions. He's an investigator on 4 randomized controlled trials in the area of early psychosis, and he was a contributor to the recently published Lancet Commission on the Physical Health of People Affected by Severe Mental Health Disorders. The title of his talk this morning is Reducing Involuntary Admissions by Identifying High-Risk Groups. So over to you, Brian, and we'll hear from you again with the live discussion. So thank you very much.
Hello, my name is Brian O'Donoghue, and I'm a psychiatrist with a service in Melbourne called Origin Youth Health, and it's a youth mental health service for young people aged 15 to 24. And I work within the early psychosis program and see young people with a first episode of psychosis. And I'm going to talk today about reducing involuntary admissions by identifying high-risk groups. So, to talk about involuntary admissions, unfortunately at times they can be necessary, but there's a number of negative aspects to it, including that they reduce and remove the autonomy for the individual. They can be traumatic, they can have a negative impact on the therapeutic relationship, and they can disrupt vocational goals as well. And this is some of the research that we did in Ireland, and I did it when I was doing my training with the St. John of God training program in psychiatry. This was done just over 10 years ago. And if we look at the number of involuntary admissions in Ireland over the last number of years, and this is from the annual reports from the Mental Health Commission, what we can see is that the number of involuntary admissions have been actually relatively stable, and on average is about 2,350 involuntary admissions per year. So so involuntary admissions affects a large number of people across Ireland. So then if we look at the most important question is, what can we do to actually reduce involuntary admissions? And a systematic review and meta-analysis has been done on this question. And the investigators found that there was 13 randomized controlled trials that included just under 3,000 patients. And what they found was that there was only one type of intervention that actually was successful in reducing involuntary admissions. And that was advanced statements. So that's when people set out in advance how they would like their treatment to be if they became unwell. And this showed a reduction of 23% in the proportion of people who had involuntary admissions. And they found that other things weren't effective in reducing involuntary admissions. This included community treatment orders, which aren't in use in Ireland. We do have them here in Victoria. Other interventions they found to be not effective included compliance, enhancement, and also integrated treatments. That's other things like having crisis teams, etc. And if we look here, this is just a different way of showing the results. But there's a few things that are kind of striking from this. Firstly is that considering the severity and the importance of involuntary admissions, it really is, that does demonstrate that there's a huge lack of research in this area if only 13 trials have been done on it. But it's also very disappointing that other interventions haven't been effective in reducing this practice except for advanced statements. So keeping this in mind that the majority of interventions to date haven't been effective, what I want to talk about today was kind of another approach at addressing this question of how we can reduce involuntary admissions. And I kind of just add a further challenge to this is that also involuntary admission rates vary from country to country, and this is most likely due to different legislations and practices in each country. So as I mentioned, a different approach could be if we identify clinical populations who are at higher risk of being involuntarily admitted. If we then understand why they have this increased risk and then develop interventions accordingly. So if we look at this from the other perspective about which patient groups are more likely to be involuntarily admitted, and this has been addressed in a meta-analysis done by this group here, and they found a number of factors that did increase people's risk for an involuntary admission, and they included males, being single and unemployed. But the two largest factors, and they had odd ratios of greater than 2, which means that they were twice as likely to be involuntarily admitted, included those people who had a psychotic disorder and also those who had a previous involuntary hospitalization. So I'm going to focus on the first one of these, which is people who have a psychotic disorder. And if we look and see about, well, what proportion of people who do have a psychotic disorder do have an involuntary admission, there's actually not a huge amount of research on this, but the research indicates that between about 50 and even up to 70% of people presenting with a first episode of psychosis can be involuntarily admitted. This particular study that was done in Canada found that the majority of people with first episode were admitted involuntarily. I think their figures are around 60%. So this is really huge. So this really indicates that the majority of people presenting with first episode can have an involuntary admission. This can obviously depend on the services in the particular area and how well developed the community services are. So to think about this again from a slightly different approach, one of the things that that's been worked on within the service that I work in at Origin has been whether we can predict and identify the people who are at higher risk for developing a first episode of psychosis. And this has been termed the ultra high risk for psychosis or the at-risk mental state. Really what it is that we can see that when people present with a first episode of psychosis, often if you ask them about the months before they present with the first episode, or even before it developed, really what you usually hear is that for the majority of people, around 70%, that they had subthreshold symptoms or milder psychotic symptoms and also drop in functioning. So what they've done over the last number of decades is really try and actually kind of operationalize this criteria to see whether you could identify those people at higher risk for developing what we call transition into a first episode of psychosis. And this has been effective between about currently about 20% to about 35% of people will transition to who have been identified as ultra high risk for psychosis will go on to develop this first episode of psychosis. But this concept has received criticism more recently, and there's been lots of kind of perspective pieces about the concept of having at-risk mental state clinics. So the concept's been challenged. And the reason I bring this up is that what it actually led us to do was to look and see, well, look, to ask the question, what changes or effects do these clinics have that we mightn't have actually originally kind of anticipated? So we did a systematic review looking at the outcomes of those people who came through a at-risk mental state clinic who went on to develop a first episode, comparing them to people who presented directly with the first episode of psychosis. So these groups of people both developed a psychotic disorder, but they had different pathways into care. So the first group through the at-risk mental state clinic, they were in the service when they developed the first episode compared to people who just presented directly with the first episode. And what we found is that there were only 4 studies that we identified in our review, in our systematic review. And one of the studies found that those people who came through the at-risk mental state clinics were less likely to be admitted involuntarily within the first year. So this led us to look at this within our own service at Origin. And what we looked at data over the course of 5 years. And during this time, over 1,100 young people were presented with a first episode of psychosis. It's a very large service. It covers a very large catchment area. And of those people, 21% of people first attended either the at-risk mental state clinic or another one of our kind of specialist youth mental health clinics like Headspace, where we've got a specialist service for people with personality disorders. And what we actually found is that there was a big difference in the rate of admission to hospital, depending on whether you came in through the ARMS clinic or directly with a first episode. There was 17% of the people who came in through the ARMS clinic were admitted to hospital when they developed their psychotic disorder, compared to 55% of people who presented directly. And then if we look at those people who were, of those people who were admitted, what we found is that 71% of the people who came directly with their first episode of psychosis were involuntarily admitted, compared to 25% of people who came in via the ARMS clinic. So what we actually see is that there's a huge reduction in involuntary admissions for those people who develop a first episode and having first come through this at-risk mental state service. And the odds ratio was 0.11 or 0.11. But if you flip this around, what it actually equates to is that people who present directly with a first episode of psychosis and not through these ARMS clinics were 8 times more likely to be involuntarily admitted. And this is currently in press. We're in preparation at the moment. And actually it's a registrar who's currently working in Ireland, Tara Burke, who looked at this data and is submitting this work. And it's also good to know that these ARMS clinics are actually part of the National Clinical Programme for Early Intervention in Psychosis. So this is the proposal that for the rollout of early intervention across Ireland. And it is stipulated in here that people should have an assessment and determined if they don't have a first episode, that they do have an assessment to see if they have the at-risk mental state. So potentially this is something that I do hope it's included in the model when it's rolled out, because it could actually lead to a reduction in involuntary admissions in this group. So then within this, I've identified obviously that the people with a first episode of psychosis have this higher rate of involuntary admission. But even within that group of people with a first episode of psychosis, there's a subgroup who have an even higher rate of involuntary admission. And that's people who are from an ethnic minority background, or who else are migrants as well. So what they did, again, this is done in a meta-analysis. A lot of work has been done in the UK, and found that people who had a psychotic disorder from Black Caribbean ethnic group were 2.5 times more likely to be involuntarily admitted. And similarly for migrants, they had a 50% increased risk of being involuntarily admitted. And we also looked at this in our own systematic review, looking at outcomes of migrants with a first episode of psychosis. What we actually found is that there was a higher rate of involuntary admission for those people who were first generation migrants. And again, it's something we actually looked at within our own service, within the early psychosis program. And what we found is that migrants with a first episode of psychosis to Australia had a 50% increased risk for being involuntarily admitted. So similar to the systematic review, and the highest risk were for African migrants, who had twice the risk compared to young people who were born in Australia. And again, these findings are in press at the moment. We also looked at it in Ireland, looking at the DETECT data. And what we found there was that there was no difference in the admission rates for migrants compared to those people born in Ireland who had a first episode of psychosis. However, of the admissions for migrants were more likely to be involuntarily. So nearly half of the migrants were admitted involuntarily, compared to 37% of the people born in Ireland. So this leads to the next question: why are people from ethnic minorities or migrants more likely to be involuntarily admitted? And the answer is, at the moment, unfortunately, we don't know. Most of the studies in the systematic review offered no explanation for this kind of increase in risk for involuntary admissions for these groups, or they didn't offer any kind of data. They couldn't back up their hypothesis with data. Other studies have said, well, there's higher rates of psychosis in this group, but that actually doesn't explain it, because the comparison group is another group with psychosis. So that shouldn't have any effect on it. So the kind of other leading theories are that there's unfamiliarity with the healthcare system, in particular in migrants, which might lead to delays in accessing care, and therefore then leading to some more severe mental health difficulties at the time of presentation. Maybe due to the perceived risk of violence by the people making the assessment and determining the type of admission. And also, it has been shown that these groups are more likely to have police involved in their admissions as well. But we don't actually know, just to be clear, that these are actually theories, but we don't know why these particular groups have higher rates of involuntary admission. In terms of, and I think that's one of the first things we do need to do, but we are also, we are also trying to adapt our services. And just to give an example of potential solution, at Origin, we're establishing a hospital in the home service, which is acting as an alternative to inpatient hospital admissions for young people from the age of 12 to 25, where they get a high level of care from being seen twice a day. And in response to the data that we've recently seen with the higher rates of involuntary admissions in migrant groups, we're trying to tailor the service to meet the needs for this community. And it's a co-design project where we're going to involve young people affected by mental health disorders and also their caregivers in the design of the service. So therefore, in summary, if we, in terms of the first group, for those with the first steps of psychosis, so involuntary admissions could be reduced by identifying those people prior to the onset of the first steps of psychosis. So identifying people in the ultra high risk stage or those with the at-risk mental state, and having them in the service, if they do transition, dramatically reduces down the rates of admission to hospital and also involuntary admissions as well. But also, furthermore, if we understand why ethnic minorities and migrants are more likely to be involuntarily admitted, then we can develop interventions to reduce this practice. And if I just go back to the systematic review looking at predictors of involuntary admissions, the other one I focused on psychotic disorders, but also the other predictor was previous involuntary hospitalization. So again, I just raised this question that if we manage to prevent the first involuntary admission, will this help prevent subsequent involuntary admissions? And that's something that we can't assume to be the case, and again, should be explored in further research as well. And finally, if we just look at the original slide, looking at the rates of involuntary admissions in Ireland, as I mentioned, that they've been very stable over the last number of years. And randomized controlled trials are really difficult in this area. But it means that if the rates have been stable over the last 4 years, that it means that we could look at pre and post changes if an intervention was introduced. And keeping in mind that even a small effect from an intervention, such as a 10% reduction, would mean a 10% reduction in voluntary admissions could mean that there was 240 less people being involuntarily admitted. So even a small change in this could have a very large impact for the people affected. So I'd like to thank you for having me, and I look forward to joining you all for discussion later. Thank you.
Okay, so thank you very much, Brian, and looking forward to talking to you a little later on. So moving swiftly on this morning, our next speaker and final speaker before the live discussion we have two people. Michael Groves is the speaker in conversation with Charles Searson. Charles is coordinator of the Wicklow Mental Health Engagement Forum, and Michael is a self-advocate with experience of mental health services. The talk or topic is recovery focused changes over the past 10 years. So over to them now, and their video will roll shortly. Thank you.
Previously, my experiences were negative in terms of seeking help, because at that stage it was only, a medication-only solution, and I found that no one was really interested in your story. Now, to be fair, many things have changed, and there's an awful lot more on offer now than there was then. My last episode of, say, Poor Mental Health was just over a year ago. When I originally approached the GP, he made an appointment with the Linkara Centre. I got to see the Linkara Centre, I think, within a week, which was very, very good and very, very helpful for me, because at that time I was feeling particularly bad. I was offered two different types of CBT. I was offered, is it dialectic therapy? Okay, I didn't know where to pronounce that right. I was offered stress management training. I was offered a course on wellness, maintaining wellness and mental health. I was offered a mindfulness program. I was brought back to see the Linkara at regular intervals for assessment, which was something that used to happen before. They generally give you your medication, go off and keep in touch with your, say, GP. I thought that was very, very helpful. They worked very closely with my own GP, which was very helpful, because between the two of them communicating, they were always on top of exactly where I was at any one time. And the treatments were, say, different insofar as this time my treatments consisted of therapy, medication, and my own resources. And that, to me, like, if you understand, was very important. And it was a huge change from what I'd experienced previously. Years ago, it was kind of the professionals telling us what to do and what to take. Now it's more what I would call a person-centric treatment. There was always an air of superiority, or a sense of kind of us and them. Today, an individual story is really important. And it's important for many reasons, not only that they know that they've been heard, but in the overall context of their symptoms, how it affects them, and getting a correct diagnosis. As a result of this, I think more trust is developed. And while the mental health professional will always be important, the patient is by far more important in their own recovery. My initial assessment this time was completely different than ever it was before. I actually received a whole copy of the assessment, which was amazing. And, it was nice to know not only what did I say, but what did they thought about what I said. A copy was sent to the GP, and I received one as well. And I thought, wow, this is really beginning to open up. On a positive note, first of all, I would say I understand the way I think, and I understand how the way I think impacts my mood, and I understand the way I think when it affects my mood, how that also affects my behavior. That is actually very, very helpful to understanding me and how I function on a day-to-day basis, and how that affects me overall in how I interact, with the outside world. I would also be more knowledgeable of what works for me and what doesn't. And I think I'm in a better place now to be able to provide better self-care for myself. Rap was great. There was questions in the rap that I've never heard anybody ever asking before. It was so detailed. Like, I mean, it was okay to have a plan, but you had to have a plan about a plan. You know what I mean? And it went into all sorts of details about, like, who would you trust if you wanted someone, like, to support you? And if they weren't available or they didn't want it, who did you go to? I never really approached them and asked them, did they want to be there? Right. I think that was what was different. So we had that conversation, and the conversation was, how do you feel about that? Stigma is reducing, but there's always going to be a problem. and the radio portrays a very different type of mental health than I've ever experienced, that I know have. Opinion is always based on the fact that you have a mental illness. So people don't take you as serious as they would someone who hadn't got one. And of all the things, that hurts me the most. It was recognizing that I'm the most important person in my recovery. That to me was a mind shift from them always telling me what to do to realizing actually, if they just empower me, I can actually do a pretty good job myself. The second one is there's no kind of one type of strategy or one type of program that gets everybody well. That program has to be tailored to each individual based on their experience, their coping skills, what worked for them, what didn't work for them. So being listened to. And this is why I've always said, about your story. Your story isn't about just what happened to you in the past, what's happening to you now. It's also about when you have been unwell before, how did you get out of it? How did you recover? Mental health professionals to listen more than they talk and to remember their story matters, even if it doesn't matter to them. I'd like them to remember that I'm a human being with feelings and to treat me like they would like to be treated. I'd like them also to use simple language and engage me. After all, I'm the real person and I live with the result of, say, yesterday's recovery programs. They simply exclude me. And yet I consider myself to be the true expert. I remember one time talking to a couple of guys. We were in the shoreline in the gym and we were discussing about, medication. And the guy said, I leave that to all the experts. And I said, well, we are the experts. They're not taking it. We're taking it. We're the people suffering the side effects. What are you talking about? That we can accept one another and that we might be portrayed in a better light. I was saying to you this, both in the newspaper and in TV, that we could work together to make the world a better and more inclusive place, where being different is normal and not seen, as a crime. And progress is being made and it's really being felt on the ground. I can see it. Some people will always fall through the gaps. And we need to consider them also. I don't know how you reach them, but I know of them and I've met them. Between the research, between the person in position making a decision and the time it takes to implement that decision, lives are being lost. Some people are suffering needlessly. Hope is being eradicated. And some people are actually giving up. Yes. I would say to those people at the conference, clap yourself on the back. Get straight back to work as you've only just begun, and your work to improve our lives and remove our suffering and torment has only just started.
Okay, sorry about that. There was some technical issue that was causing me to be on mute and I couldn't unmute myself. So thanks very much to Michael and Charles. That was a really uplifting recovery story. And technical issues aside, we've gotten through the morning's talk, so that's great. And we're now on to a live discussion. So we're joined by many of the people you've heard from this morning. Michael Groves and Charles Searson there. Anya Flynn is joining us there, who gave us the first talk. Michael Keating has just come in there, so that's great. And Brian O'Donoghue from Melbourne. And then we're also joined by Emma Balmain, CEO of St. John of God Hospital, and Teresa Mallon, Head of Quality in St. John of God Community Mental Health Services, or Community Services, I should say, not just mental health, but also intellectual disability. So we have a couple of questions that were posed by people who'd signed up for today. So I'm going to take them and I'm gonna put them to a few of the people. So the first question, and I'm going to paraphrase it, is really about the balance of the rights of families and the rights of individuals, and what the upcoming legislation in Ireland, the Capacity Act, might mean for that, and whether it offers any change in that, and how we best deal with some of the difficult scenarios that arise when trying to balance that. So, Anya, can you talk to that first, if you don't mind?
Thanks, Larkin. I am audible, am I? Yep.
Yes.
Great. Yeah, in terms of the rights of families, I suppose important to say that the 2015 Act relates to adults, and that adults do fundamentally enjoy decision-making autonomy. I referred in my talk to this established but unfounded idea that people who are the next of kin, so-called, have some decision-making role or are the people to look to for consent. And that isn't, and it can come as a bit of a surprise, that isn't based on anything. Next of kin means something when you're dead. It has a meaning in succession law, and it doesn't actually apply in the here and now when people are still alive. So I appreciate that can cause challenges within a family dynamic when obviously the families and people living closest are potentially most affected by decisions, particularly around healthcare in the area of mental health. It isn't true to say that a family member has no role. They may well be best placed to provide, and in fact the Act states that a healthcare professional can confer with a family member, but it's really with getting to the heart of what the individual person's will and preference is, rather than substituting what the family wants and proceeding on that basis. So I appreciate that can come with challenge. And also, will and preference, just to be clear, isn't about wish fulfillment. You don't get your will and preference just because it is your will and preference. And rights exist together with responsibilities, and often there will be some balancing exercise to be carried out to determine where one person's rights overlap with another. So I appreciate that may not provide a full answer, but I think it's important to reframe the question that the idea of the rights of a family member is perhaps not your starting point. And certainly thinking of the 15 Act, it is person-centred legislation, and that's where one needs to begin.
Excellent. So thank you for that. I might just put a scenario to a couple of the other panel members just that came to mind as you were saying that. So I was contacted yesterday by a patient of mine who said he has schizophrenia, and he's been through a number of very, very difficult involuntary and voluntary admissions, preceded by situations with the Gardaí, with heartache for his family. And we've had a number of family meetings at which we've agreed that if he stops taking his medication, we become aware that his family should be informed, and he has agreed with that. But he contacted me yesterday to say he wants to stop his medication, and he refuses to allow us to inform his family with whom he lives. And no amount of persuasion could change his mind on that. And he, became quite insistent and spoke to his rights. So Brian, I might put that scenario to you as something you might be familiar with, and then I might come to Charles and Michael Groves about it.
Yeah, absolutely. I think it brings up, all the challenges of the work that we do, and I might just talk more generally just about the point that came up there a moment ago, because one of the things, as I mentioned, I work for a youth mental health service, and it goes from 15 to 24-year-olds. But what that actually means is that we're looking after people, who are, some people are children by law, and then other people are young adults and are not subject to that. So we actually have we've got this kind of case mix within our clinical work, which makes it more complicated. But in some ways, we approach it with the same philosophy, which is involving the family as much as possible, and in discussion with the patient. But also, one of the other strategies we found very helpful is actually having an independent team member who works with the family. So we've got in our service family peer support workers, and they're people with lived experience who have cared for someone suffering, for a young person with major mental health problem. And what they do is they contact all of the family members within our service. And they actually contact them regardless whether we consent or not. We've got approval to do that, because sometimes they don't have any information they have no clinical information, so the confidentiality sometimes can't be breached because they don't have that information. And they provide a lot of very practical support, and lots of times the scenarios that come up are scenarios that are, you know, general, that they've come up previously before. So these peer support workers have the experience and the knowledge of how to, you know, for families, how to manage these situations. They might be quite general, but it actually can, you know, they can tailor towards it. So that's just a general approach, how, you know, and we find that works very, very well. But I think that's as you mentioned, that's tricky in the situations. And I wonder, I'm not clear on the specifics of the law in Ireland, but obviously the advanced care directives, whether they can be incorporated, you know, those statements about informing people, I'm not sure. But I think having you know, having people who work directly with the family and the teams, I think are very, very helpful, because they're not conflicted with that information. So I think that's one of the first approaches that we do take.
Thanks.
Then, yeah, the other thing I'll just say is, sorry, on that note, sometimes I also mention to families that obviously we can't breach confidentiality. But well, I tell them that there's certain situations where we can breach it, and I outline those situations, and then I can tell them that, look, if I'm not breaching, like if I'm not giving you that information, you can then know that that's not occurring. So, you know, it's a bit of a roundabout way, but at least they know. The family members are reassured that things aren't imminent or immediate, there's immediate risk, because they know that in those situations that we are going to inform them. So we're very clear about that. And then the last thing I'll just say is that we're also very open with our patients about what we're doing, who we're telling what we're doing, because I think just being open and upfront about all these things in the long run is also more productive in maintaining that therapeutic relationship.
Thanks very much, Brian. And we are thankfully moving towards having more peer support workers and others who can, you know, help in these situations. And I think also as mental health professionals, we're moving to, you know, appreciate people's right to make decisions that are unwise and support them in that, and try and find the best way to support them, the family at the same time. So what about Michael or Charles? Do you want to speak to any of that? Michael,
Well,
I'll get you to go first.
Yeah, okay.
Well, thanks a million for that, Michael. It's great to get real world situations, because often, you know, the practical reality of trying to deal with those things, you know, we all struggle with it, and legislation does its best to protect rights, and but sometimes it doesn't solve everything. Charles, do you want to add anything quickly to that before we go on to one more question?
One of the reasons I became involved in all of this is because I'm a supporter, and I think there is something about a person in a family or family of choice going into crisis having a knock-on effect or a systemic effect on everybody else. So, you know, everybody in the family is in effect in crisis, and our whole system of care is about the patient, which is effectively a patient record, which means a one-on-one mapping. And to look at things slightly more broadly is very difficult the way our systems are set up. Apart from the mindsets of the teams and the professionals of the teams, which can be quite broad, the systems that support them actually narrow things back down again. In terms of rights, I think everybody has a right to good mental health, and I very much liked the way Brian spoke about the idea that, you know, we can get somebody who's unconnected to the individual, not sharing any clinical information, to support the supporters or support the people who are affected. That seems to make an awful lot of sense to me. And in terms of education, we're talking about recovery-oriented services and moving things back out into the community, and people doing a lot of their recovery at home are, you know, then it's really essential that we all start to pay attention to what supports a supporter might need, what education a supporter might need. And that doesn't mean that they've necessarily gone into crisis themselves, but it does mean that we stop them from doing so, and give them every possible resource, so that there's, you know, there's a kind of a safety net around a person coming back into the family out of crisis, or better still, positive supports for a person who has had a previous episode, not to go back into crisis. And I suppose something like RAP really helps, because it talks about supporters and supporting supporters, and that everybody has a chance to talk about minding their own mental health. And of course, the whole idea of RAP being the advanced planning side of things. And my understanding, and perhaps somebody in the panel can confirm this, is that advanced messages, or advanced, not directives, but, you know, advanced planning doesn't really have any force. It's got to do with the relationship you have with your individual team as to whether it's even going to be respected. But I love the idea that it's been, you know, there's some evidence saying, look, well, it actually reduces involuntary admissions if a society works that way. It's fantastic.
Great, thanks, Charles. And in the interest of time, I'm going to move on to a second question, but we could talk all day about that. And so the second question that was posed by people who had signed up today was, how have human rights awareness and development progressed in Ireland, particularly for individuals with intellectual disability in the last decade? And I might come to Michael Keating to answer that question first, if that would be okay, Michael.
Okay, thanks, Larkin. And I guess Dr. Emily Logan and Anya Flynn certainly set out the legislative changes over the last 30 years in relation to human rights. I guess what I'd like to focus on really is residential care, and talk about it at a practical level. So how rights have progressed, I suppose, is through the move away from institutionalized care in particular within residential services, and the move towards community-based care. And that began, I suppose, in the early 90s, you know, where people began to move into smaller community-based homes, where you or I live, generally with between 4 and 6 people living in those houses. So I guess at that time it was a move away from what was called the traditional medical model of care towards a more health and social care model. And I guess then, you know, in the early 2000s, then as we progressed, we had the time to move on from congregated settings report. And I suppose that really shone a light on the amount of people who were still living in institutional care. And when we talk about institutional care or congregated settings, we talk about, you know, places like where there are multi-occupancy rooms, people are living in dormitory style living. And I guess, you know, now more people have moved away from that, albeit some of those services are still in operation throughout the country. And I guess also I would like to think that the role of regulation has played a part in enhancing, or certainly acknowledging, the rights of people with disabilities living in residential care. So, regulation began in 2013, and that was, I suppose, the first independent monitoring and oversight of residential services. And while decongregation is not in the remit of HICWA, I suppose it's had a knock-on effect in relation to driving that agenda forward. And particularly, in organisations such as St. John of God, where they have moved an awful lot of residents out of congregated settings into more individualised care and support. And I guess it can't be, it's easier to provide person-centred care to a fewer number of people within a community centre, a community house, I should say, sorry. And I suppose finally, I'd just like to say, I suppose our annual, HICWA's annual report from last year very much focused upon evidence from inspections that congregated settings had higher levels of non-compliance with the regulations measured against non-congregated settings. So, and this resulted in poor outcomes for the residents living in these centres.
Thanks very much, Michael, and it's good to hear of positive developments, and how HICWA is contributing to driving them forward. And maybe from a service provider point of view, Teresa, you might come in and see what it's been like trying to, bring on those developments.
Yeah, thank you, Larkin. And I suppose just following on from what Michael has just stated, we certainly have welcomed the work of HICWA on the ground in relation to the improvement of quality of life of people in St. John of God Community Services and the improvement quality of service provision. It's fair to say that, as Michael stated, there are still 2,500 people in Ireland living in congregate settings, which is a significant issue in the context of their human rights. It's fair to say as well that I suppose with the introduction of regulation, what it did do for the service providers is it, I suppose, put a bit of weight in relation to getting the funding that was required to support people transition to homes of their choosing within the community. I mean, St. John of God's were involved in provision of services since the 1940s, and I suppose in that context we're involved in more congregate institutionalised settings, which was the practice at the time, but over the years have progressively worked towards the social care model and more recently towards the human rights-based approach. It's fair to say that if providers were aware of, in many cases, the need to progress services and provide a more quality-based service to people and more person-centred services, particularly for those living in congregate settings. However, in many cases, the funding did not, I suppose, meet the requirements. And I suppose it's fair to say that nationally, the funding model is not aligned to a human rights-based approach. So I suppose in the context of all of that, there are many things that has, over the last number of years, that has, I suppose, led to a more person-centred service model and a more human rights-based model. And it's fair to say that St. John of God's over the years have been very innovative in relation to their approaches. And in the 1970s, again, following on what Michael outlined in his presentation, in the 1970s, St. John of God Order established the Callan Institute, which is a standalone and one of its, I suppose, the only service nationally that is a provider of best practice positive behaviour support in Ireland. And I suppose they looked at international research in relation to this and have developed multi-element behavioural model which has worked really effectively in relation to addressing restrictive practices that Michael spoke about earlier on, and has provided significant training not only to staff within St. John of God's but also to people external to St. John of God's. And also, I suppose, the whole area of person-centred planning has been significant in the whole sector. And again, St. John of God's in the 1980s and 90s were engaged with John O'Brien and from America, who is a leader in the whole area of social inclusion. And I suppose that model, that whole person-centred planning movement then led on to the development of more community-based residential services and supported living services. And alongside that, John of God's were innovators in the whole area of sports and employment, which was supporting people to secure mainstream employment in the open labour market. They engaged in are linked in with the Open Training College in relation to training their staff in the whole area of as job coaches. They gained professional qualifications in relation to that. And I thought that was significant in the context of, I suppose, from a human rights-based approach. So I suppose there's been quite a lot of developments over the years in relation to driving towards a more human rights-based approach. And as Michael rightly said, what's supporting that now, thankfully, is national policy. So the Transforming Lives policy that was national policy that was launched in 2011, again, is given weight to the whole decongregation agenda. However, the funding that is required and has been required over those years has not been fulfilled to date, and I suppose we look forward to that happening in the future. And I suppose
we do indeed. I might cut you off, Teresa, just because we're getting short of time, and but it is it's an impressive tradition, and long may it continue. Hopefully, that funding situation will positively develop. But I want to finally go on to Emma, and I might extend the question to the area of dementia care, and because it's very relevant in that area too. So I wonder if you could answer that, Emma.
Thanks, Darkin. And I guess maybe some people on the call may not be familiar with St. John O'Groats Hospital and our service in Shankill, St. Joseph's, which is a specialist dementia service. I suppose what we'd have to say in relation to what's happening in terms of a rights-based approach for people living with dementia is that, yes, there's certainly movement, but there's certainly a lot more to do. It is heartening to see the developments in intellectual disability and mental health, but really in relation to dementia, we need to change people's attitudes and make sure that people understand that a person living with dementia has the right to live a quality life right to the end. And I think we've had a very interesting journey over the last 10 years in St. Joseph's, and I would have to say, I'd echo Teresa's comment that I think certainly HICWA and the regulation of older person services has helped us on that journey. So we now are very much a person-based service in our residential and our daycare service there, but there are many examples whereby people living with dementia, be it in residential care or in the family home, are actually just living and existing. And I think that needs to change, and their rights need to be recognised. And as Charles said earlier, it's a very stressful time for families and their supporters. So my view is that we need to do a lot more about communicating with families and society in general in terms of educating people about rights-based care, about person-centred care, and about the legislation that Anya has spoken about so well this morning. I'm not so sure that the general public are as familiar with it, and I think that's our job. We need to advocate, but also encourage others to advocate. So I think there has been progress, certainly, but I would like to see much more, and particularly in the realm of people living with dementia. Larkin.
Okay, thank you very much, Emma. And time is up, they tell me, so I'm going to thank all of the panel for their contributions this morning. I think it goes a long way towards just what you're talking about, Emma, about educating and bringing the message to the wider public and professionals and etc. So thank you, everybody. I'll just say that the video of today's whole conference will be available to everybody, and the link will be circulated. And then just to say that the next Tuesday there's a carry-on conference, and the theme is different. It's the impact of COVID-19 on the health of the population, and hopefully you'll all find your way there. So the Research Foundation website will have the video of today's session if people want to, if anybody missed any bits of it or wants to review anything. So thank you, everybody, and goodbye. Thank you.